With that, let me introduce our next speaker, who really have pioneered the area in looking at interrelationship between diabetes and pancreatic cancer. Dr. Suresh Chari, all the speakers' bio is in your program. So I will not going to introduce them so that you can look at who they are. The only thing I can say about Dr. Suresh Chari from Mayo Clinic, he basically had looked at all this disease at the very early, at 10 years ago, and now being supported not only by the National Cancer Institute to start working on the clue for diagnosis for pancreatic cancer. So, Dr. Suresh Chari.
Thank you, Aggie, and thank you, Bill. It's always inspiring to be among not only the physicians and scientists who are working on this, but also survivors and the patients who inspire us to do the work we do. 20 years ago, I started working on this, and I had decided that my only contribution to the field would be if I made a difference in the early detection field because of the issues that I'll show you we face with pancreatic cancer. So for this particular presentation, I want to acknowledge this young man, Ayush Sharma, who has done an enormous amount of work, almost worth a PhD in a very short amount of time. Almost all the data I'll be presenting today comes from his work. So if you look at the progression of pancreatic cancer, the normal progression, like most cancers, it starts confined to the pancreatic duct, and it's called carcinoma in situ. That means it's a cancer that's confined to the duct of the pancreas. And somewhere between 4 or 5 millimeters to 10 millimeters, it starts to invade the pancreatic duct itself, and it's called invasive pancreatic cancer. The classification of pancreatic cancer calls anything which is 20 millimeters or less as small, and at this point, about 40 to 50% of patients will have at least regional spread of the tumor. The average size of a tumor that's removed at surgery is around 30 millimeters. But and the problem is at the time we make the diagnosis, the tumor is not removed by surgery in 85% of patients. And this entire pre-diagnostic phase is not available for us to interact with. And this is the biggest problem, is that there is no early detection strategy. So our hypothesis was, if pancreatic cancer is like an unquenchable fire at diagnosis, it must start as a small fire at some point and maybe just smoke. And so if you go back in time, could we actually catch it when it's a small fire that is extinguishable, or even catch it when it's just smoke? So this has been our work for the last 20 years, looking back and seeing what clues it is giving. So what we have done is looked at a variety of factors that occur in the 5 years preceding pancreatic cancer diagnosis, and trying to go through these stories and trying to see what clues we might find there that might help in early detection. And I'll go through this is a limited number of factors we have looked at. There's many other factors we've looked at, but these all have some information that is useful for early detection. So what we have done is looked at symptoms, and not just us. Many people have looked at it, and I'll just present to you the data from 700 patients in whom we abstracted symptoms from the charts to see what clues they might have in terms of earlier diagnosis. And then in a very epidemiologically rich population, we looked at a number of common biochemical tests that are often ordered by physicians that might give us a clue for early detection. And finally, at Mayo Clinic, we have a number of patients who had serial CT scans, and we look back at that scans of patients who finally got diagnosed with cancer but had previous CT scans to see what happens to soft tissue, fat, and muscle in these patients. So the Rochester Epidemiology Project is a very interesting project. The NIH has funded this since 1964. It basically connects all the caregivers in the Olmsted County population into one medical database. So regardless of who you go and see, you can go to this database and find what happened to that interaction between the subject, patient, resident of Olmsted County, and the healthcare. So in that population, we identified all patients with pancreatic cancer in a 15-year period and found controls of similar age and gender and BMI. And that is many of the data, much of the data I'll be showing will be through that. And then we also looked at a group of subjects who had serial CT scans, and we were able to retrieve all those CT scans and go back and look at what happens to muscle and soft tissue in that. So this is the story of the symptoms, and when we abstracted symptoms from the chart as to what the patients complained to their primary physician or to the physician that they were seeing, we found that almost all the symptoms were confined to the last 6 months. And actually, if you further refine this, you will find that the majority are in the last 3 months. And if you go back beyond 6 months, the symptoms rapidly become very infrequent. And so this is something that we realize is that if you look for traditional symptoms of pancreatic cancer, you will not find early disease, and you'll have to go back in time at least 3 to 6 months before that. So many of my graphs are going to be in this format, so I'll take a few minutes to describe this format of the data presentation, and then you can follow the rest. So this is a plotting of the blood sugar going back in time for 5 years. And the right on 0 is at diagnosis, and minus 60 is 5 years past previously. You'll see that there are 2 curves. One is a case and one is a control. And these are blood sugars at every 6 months. Olmsted County is unusually dense in terms of the number of blood sugars that are done in the population. And so we were able to get fairly good data density here. And this is a plotting of the blood sugar in cases, all the cases in Olmsted County versus controls. And what we found here was that the blood sugars start to rise in cases about 30 to 36 months before the controls. And between 9 to 12 months before diagnosis, they cross the threshold for diabetes. And then it continues to rise after that. So this suggests to us that there is a window of opportunity of 30 to 36 months in which we can intervene and find the lesion if we had other clues. One of the things about pancreatic cancer is that the diabetes in pancreatic cancer has this very paradoxical phenomenon which we have observed for 20 years, and that is that the weight drops in the face of rising glucose. This is completely paradoxical. In type 2 diabetes, you gain weight and therefore you become diabetic. Here, you're becoming diabetic in the face of weight loss. This is something we knew right from the very beginning, but we actually plotted this in this population. And what you will see is that the weight is deviating in the controls compared to cases about 18 months before diagnosis. So there appears to be this paradox between rising glucose and drop in weight, starting 18 months before. So what we did was we quantitated this paradox. That is, we took age, the change in blood glucose, and the change in weight, and calculated a score that is called the Enriching New-onset Diabetes for Pancreatic Cancer score. And that score, when applied to a subject with new onset of diabetes, actually risk stratifies the new onset diabetes into 3 groups. One group has extremely low risk of pancreatic cancer. They're basically type 2 diabetes, and their risk is almost 0. And then there is the other group that has very high risk. They have a score of 3 or more, and there the risk is nearly 7% after you clean this data set. So we found that this score was able to risk stratify patients into those with very low risk and those with very high risk, and then an intermediate risk. So this gave us an opportunity to not only look at new onset diabetes, but also to risk stratify them and look at a very high risk group for pancreatic cancer. So you might ask, what is the point in looking at diabetes? How often does it occur? So what we did was the same patients that I just told you, we divided them by their glycemic status at diagnosis. And you will see here that 22% of pancreatic cancer patients have new-onset diabetes. Another 20 have long-standing diabetes, and they go through the same destabilization of their glucose prior to diagnosis. And another 13 have advanced pre-diabetes. They're just close to becoming diabetic. So if you look at diabetes itself, nearly 55 to 60% of patients have diabetes or pre-diabetes, and therefore, this approach to early detection will capture a fair number of patients with pancreatic cancer if we can take this further. So one of the questions we had to answer was what happens to lipids in pre-diagnostic pancreatic cancer? So here's the background. In type 2 diabetes, as you gain weight, your triglycerides and your cholesterol go up. This, we know that obesity, diabetes, and high triglycerides and high cholesterol all go together. And this is called a metabolic syndrome. And rising glucose in pancreatic cancer should be associated with rise in lipids, because if it is a part of the metabolic syndrome, it should also cause a rise in lipids. But patients with pancreatic cancer lose weight, and weight loss causes drop in lipids. If you lose weight, your cholesterol gets better. So which way would lipids go in pancreatic cancer? Because it has both the rising glucose and a loss of weight. So it was something that we could not answer up front without any prior knowledge of what is going on. So we actually looked, and interestingly, the lipids start dropping 18 months before diagnosis. Just when the weight starts dropping, the lipids start dropping. And so the cholesterol, the triglycerides do the same thing as the cholesterol does. It's just remarkable that the consistency with which we found this in multiple data sets. We have 2 different data sets, and we check this out, and it checks out. So this is remarkable that we are finding this phenomenon of a drop in lipids and a drop in weight while the sugar is rising in these patients. And the low-density lipoprotein, which is also carrying cholesterol, we'll see that that also drops 18 months before. So there is a pattern of certain lipids which start dropping 18 months before diagnosis. The high-density lipoprotein, on the other hand, drops only close to the end, nearly at 6 months, and we believe this has a different mechanism for its drop. Interestingly, we had postulated that the phenomenon of drop in weight and drop in lipids was because there was browning of white fat. There is 2 types of fat we have. One is white fat, which is the majority of fat we have. As children, we have as neonates, we have what's called brown fat, which helps generate heat so that this newborn that is naked will maintain his body heat. And as adults, we tend not to have too much of brown fat, but pancreatic cancer converts white fat into brown fat, and that's how it causes drop in weight and drop in lipids. And we postulated that if that hypothesis were true, the person's body temperature would go up. And lo and behold, that same evening, we had the graph of the temperature, and the temperature goes up in patients with pancreatic cancer starting 18 months before diagnosis, again, supporting our hypothesis that was browning of white fat. So there's a whole bunch of things going on in the time before the cancer diagnosis that give us an opportunity to make an earlier diagnosis. So we looked at what happens to soft tissue. We were talking about drop in weight, drop in this. So where is the weight dropping? What part of the body is being lost? So we looked at abdominal CT scan and tried to measure subcutaneous adipose tissue, that is the subcutaneous fat, the visceral adipose tissue, and muscle, and try to understand what part of these compartments is being lost during this 18 months before diagnosis. And what we find is that the subcutaneous adipose tissue starts dropping at the same time as the weight and the cholesterol and the triglycerides. So these all go together. And this starts way before the patient actually complains about it. They're feeling good at this time. And that's because it's a physiologic-like weight loss, and the patients take credit for this weight loss. It's very common. I ask patients, what about the weight loss you were having last year? Oh, I did that. I started cutting back fats. I started doing this. Because it feels good. It actually does not cause pain. It does not cause fatigue. There's no muscle loss, as you will see. And so patients feel like they are the ones doing it, but it's actually the cancer helping them do it. The visceral fat doesn't go down until the very end, and it happens only at 6 months before diagnosis. And the muscle only drops at the very end, and this is when the patient feels the weight loss. They'll tell you they've lost weight for 3 months, and that's because that's when their muscle loss happens and they start feeling fatigue. And so there's a difference in the weight loss that starts at 18 months and the difference in the weight loss that starts close to the diagnosis. And one is cachexia, we call the other pre-cachexia, but the mechanisms are different. One gives you an opportunity for early detection, other one signifies fairly advanced disease. So in summary, you'll see this whole bunch of graphs we have drawn here. There's many more things that we have looked at, but they don't contribute to our understanding, so I didn't put it in here. But there is muscle loss, which happens at the very end. That goes with visceral adipose tissue and HDL. All these go down at the very end. The subcutaneous adipose tissue, lipids, and weight go down starting at 18 months before diagnosis and continue all the way down to the end. And the temperature goes up with the adipose tissue loss and the lipid loss and the weight loss. The fasting blood glucose actually rises first. It rises before any of these other abnormalities happen, and that starts 30 to 36 months before. So we thought there were 3 phases of these metabolic changes that happen in pancreatic cancer. The first phase is between 18 and 36 months before diagnosis, when the glucose starts rising. It's very silent. You wouldn't know the difference between that and type 2 diabetes. In the phase 2, that is between 18 months and 6 months before diagnosis, there's a whole bunch of things that go wrong. They don't seem like they're going wrong. They actually seem like they're going right, because they're losing weight, they're dropping their lipids. It all feels good, but it's in the wrong direction when you look back, because it is happening in the face of rising glucose. So this is the paradox that separates it. And at the very end, there is stuff happening that is a marker of cachexia, which is considered to be a feature of advanced disease, where you're losing muscle, you're losing high-density lipoprotein, and you're losing visceral fat, along with continued rise in glucose and continued drop in lipids. And as I said before, we thought that this was because of what we call browning of white fat. The pancreatic cancer was converting white fat into brown fat and burning it. What it gets out of it, I'm not so sure yet, because browning actually literally burns fat and gives you molecules of carbon dioxide and water, and the 1 molecule of glycerol. So the cancer must be deriving some other benefit from this, but it is, that's what it is doing. And so to test this hypothesis, we biopsied the subcutaneous fat. It's very easy to biopsy the if patients say take more, it's actually pretty easy to take a biopsy. And when we measured a key gene that causes browning of white fat, that is called uncoupling protein 1, we found markedly increased levels of uncoupling protein 1 in the subcutaneous fat, suggesting that our hypothesis that this was due to browning was true. So this is where we are with our understanding of the metabolic abnormalities in pancreatic cancer. So where do we go with this? So these suggest that there are 3 distinct phases, and they are progressive in the pre-diagnostic phase, starting about 2.5 years before diagnosis. Weight loss in phase 2, which starts around 1.5 years before diagnosis and precedes muscle loss, is likely due to browning of subcutaneous adipose tissue, which has a marker. And UCP1 overexpression in the SAT biopsy, it may be a biomarker of pancreatic cancer in weight-losing subjects with new-onset hyperglycemia. This is what our current understanding is of these metabolic abnormalities. We still don't understand the whys and why the cancer is doing it and so on and so forth, and there's much more work to be done. But we have a vision for early detection, which is based on this body of work. We believe that if you take the general population and then find a high-risk group within that general population, which is at least at 6 to 8 times higher risk of developing pancreatic cancer compared to the general population, that's the starting point for us to start looking for pancreatic cancer. We enrich that population, and then you find the lesion. So this is called the DEF model, or define, enrich, find model for early detection. And we believe new-onset diabetes is that starting point. We are working on looking at long-standing diabetes and how to enrich that population, but that universe of long-standing diabetes is fairly large and requires some work to enrich it. The model that we have would be the enricher right now. We would use the NPAC model to enrich these patients for pancreatic cancer. And then if the UCP1 story that I just told you is actually true and is validated, it could be used to further enrich this population. And then we would image them to find the lesion. Now, this is actually in action right now. It's called the Early Detection Initiative. And in a very unusual arrangement, there is a very collaborative arrangement between the National Cancer Institute, the Pancreatic Cancer Action Network, and I know that Bill Go and others have been very instrumental in getting me where we are here. Without their help, I wouldn't be here. But at this point, they are willing to invest the money to take this forward, and together we think that we will be able to come up with a clinical strategy for early detection that would at least start with new-onset diabetes and then can be extended to other subcategories. So I'll stop here and take questions. Thank you. Yes. The question was, have we looked at sodium? We have not, but we can certainly do that. I don't know how often it is done in a routine checkup. It has to be done fairly commonly in a routine checkup for us to be able to do the studies we did, because these are retrospective studies on tests already done. So they have to be commonly done tests for us to be able to plot this. So, yeah.
Question? Oh, very impressive talk. Thank you very much. My question is, have you, the hyperglycemic, new-onset hyperglycemia and diabetes, indicator, and the lipid change and the weight change indicators, have you looked at, that we've, it's been known for a long time, of course, that development of diabetes can be a predecessor of development of pancreatic cancer, but have you looked at other, in terms of the changes in lipids and the changes in weight and metabolic trends, have you looked at patients that have ended up developing lung cancer or other solid tumors to see if you have, similar changes there, whether that was not unique to pancreatic cancer?
So we have shown before that the new-onset diabetes development is unique to pancreatic cancer. We have looked at colon, breast, lung, prostate, all the big five we have looked at, and new-onset diabetes is not seen in those conditions.
Right, that's the diabetes
yes.
side, but the other
yes,
side.
This lipid stuff is hot off the press.
Right,
it just came out a week ago. We haven't had a chance to look at other cancers. We have colon that we have abstracted data on, and in colon didn't show any signal, but we were not ready to put that in the paper yet. But once we do colon, lung, and prostate, we might be able. So you must remember that if this is related somehow to the cachexia, these other cancers don't have too much of that. You may have to look at the subset of breast cancers that's most aggressive in order to be able to kind of mimic that with pancreatic cancer. And there you might
it's more in the metastatic phase where you get another cancer.
Agreed.
Right. And real quick, the mechanism of the association between the new-onset diabetes that predicts for development of pancreatic cancer, which seems to be more, of course, more like a type 1 diabetes. Do we really know what the actual mechanism is with pancreatic cancer?
We have spent a lot of effort on that.
We know the beta cells are in the pancreas and the cancer is in the pancreas, but what's going on?
It's not type 1. These insulin levels in these patients are high.
Right.
So this is an insulin-resistant state, and the insulin levels are high. And we believe that exosomes shed by the pancreatic cancer, which are vesicle-bound things that contain all kinds of stuff in them, are the ones causing all these effects on the different parts of the body. The cancer is commandeering the whole body to get its nutrients. And it's doing that through a messaging system that is currently understudied. And we believe exosomes carry the cargo that has the necessary ingredients in it to cause changes in beta cells, cause changes in fat, changes in other things, immune cells. And we have shown that in immune cells, fat cells, and
Right.
beta cells, exosomes get in and mess around with their metabolism.
And those exosomes are apparently unique to pancreatic cancer because you don't get this
Exosomes are not unique to pancreatic
No, I
cancer,
know the
but
exosomes
those
are not, but that
exosomes,
type of exosome.
yes,
Yeah,
yes,
yeah.
yes. But
Very interesting.
we aren't there yet to be able to tell that this exosome comes from pancreatic cancer and this one is normal. We are not there yet. So,
Thank you.
yeah.
Hang on a second, Dr. Reber.
Yeah. So the question was, can we use hemoglobin A1C instead of fasting glucose? And that's a very important question. We're actually struggling with that right now because all our data was generated with fasting glucose, and the Kaiser group has all the data on A1C. And so they have reproduced everything that we have done using A1C. So we think that the fasting glucose and A1C equivalence is not the same as what the ADA thinks it should be. That is, fasting of 126 is not equal to A1C of 6.5. We think it should be 6.3 if you're using A1C. But they have reproduced the entire body of work we have done, has been revalidated in the Kaiser group with the NPAC model, the incidence of pancreatic cancer, everything. But they have used A1C and we have used fasting glucose, and we are trying to find where the equivalence would be for the A1C compared to fasting glucose. But the signal is there in both. So you could.
One last question, Dr. Chari. So you were extracted for colorectal cancer, but in terms of the pre-cachexia, did you look at other tumor types?
It's very easy to do in the Rochester Epidemiology Project. We just haven't had the bandwidth to do it. But we were just looking at pancreatic cancer, but it's easy enough to extract that for lung cancer or prostate. More common cancers, we would have even more patients than we have for pancreatic. So, yeah.
Hi, thanks for being here. I almost chuckled when you said about patients who often are so proud of themselves for losing weight. And I'm one of those people, but I can tell you I was on Weight Watchers for a couple years, and I remember filling out the paperwork and said, have you lost more than 10 pounds in the last year? I said, well, of course I have. I just would like you to consider if there's a possibility that possibly losing the weight might be what triggered it.
It's a good question, and I think that it is possible that the pancreatic cancer is actually stimulating your brain to want to be able to lose weight. I don't know that. Somebody else also mentioned this, that did the cancer induce the desire for you to do something? I don't know. It is possible. Or you start and it just helps you a greater much more than you would ever expect it to. When I ask patients, have you lost weight before? And they said, yeah, we've tried. It's not been this easy. So the ease with which it comes off is something that is, I think, the help you're getting from, the assist you're getting from the cancer in terms of why it's so easy to lose weight. So, but this is a very common observation patients have made and physicians have made. So your experience is very typical. Thank you.
Thank you. Thank you, Suresh. Just to add to what he says, thanks to our lobbying, we are really good lobbying. The National Cancer Institute have provided the consortium studies, for which UCLA is one of them, and there are $35 million to look at early diagnosis. There's a program on chronic pancreatitis. We will bring that out to you. We're talking about today. So there are a whole bunch of programs right now being initiated through our lobbying. So thank you for some of you who help us do this.